Our next presentation is by Dr. Maria Eugenia Socias from Buenos Aires, Argentina. Dr. Socias is an infectious diseases physician and researcher involved in the Seek, Test, Treat and Retain program with a particular interest in vulnerable populations, and she's presenting on the retention in service for between 2000 and 2012 of transgender women on behalf of herself, other researchers including those from British Columbia, Vancouver.
Thank you. Good morning, everyone. First of all, I would like to thank, I would like to thank the scientific committee for giving me the opportunity to present this work to do today on behalf of the rest of my co-authors. As in other parts of the world, in Argentina, transgender women are a highly vulnerable population, as demonstrated by a life expectancy of approximately 35 years and an estimated HIV prevalence of 34%, approximately 90 times higher than the estimated HIV prevalence in the general population. In an effort to improve gender equity for LGBTQ populations, in the last years, Argentina has passed several policies and legal amendments, including the 2007 Buenos Aires City Resolution affirming the right to self-perceived gender identity in healthcare settings, the same-sex marriage law in 2010, and the gender identity law in 2012. However, and despite these progressive and novel policies and significant burden of HIV infection among transgender women in our country, little is known about engagement in HIV care among this population. Therefore, the objectives of our study were first, to characterize engagement in the HIV continuum of care among trans women enrolled in a public HIV clinic in Buenos Aires, and second, to explore factors associated with virological suppression at 12 months of their HIV diagnosis. This study was a retrospective clinical chart review of trans women who were newly diagnosed with HIV and started care in our hospital between the year 2000 and the year 2012. Thus, our study population, and therefore the denominator we use for all of our calculation, refer to HIV-positive trans women linked to HIV care in our hospital. The other indicators we assessed to characterize engagement in the HIV care cascade were engagement in and retention in HIV care at 12 months, initiation of ART, and virological suppression also at 12 months of HIV diagnosis. Although no standardized definitions exist for these metrics, we follow and adapted those most widely used and accepted. For the analysis, we calculated percentage of HIV-positive trans women at each step of the HIV care cascade within the first year of their HIV diagnosis. And we then performed B and multivariable logistic regression analysis to investigate factors associated with virological suppression at 12 months of their diagnosis. In this slide, selected baseline characteristics of the 69 HIV-positive trans women included in our study are presented. As you can see from data in the table, vulnerability among trans women in this sample was high, as shown by low rates of extended health insurance and formal employment, as well as high rates of substance use and engagement in sex work. With regards to their HIV infection, median time to linkage to care was approximately 5 months, and baseline CD4 260 cells. Further, and despite most of the trans women included in the study were in need of ART at the time of their HIV diagnosis, as suggested by their CD4 cell count, median time to ART initiation was more than 10 months. In this figure, you can see the HIV care cascade during the first year of HIV diagnosis among our trans women population. As you see, of the 69 women linked to HIV care, 61% of them had at least 2 HIV-related visits during the first year, 46% remained in care at 12 months, and 38% initiated ART. The only factors associated with ART initiation in this study were older age and, as expected, lower CD4 cell counts. Finally, only 16% of them achieve undetectable viral load at 12 months, the ultimate goal of the HIV care cascade. Even if we only look at trans women on ART, this number is still low, as only 42% of them were virologically suppressed at 12 months. We then investigated potential factors associated with virological suppression at 12 months. As you can see in the bivariable model, both higher level education and formal employment were positively and significantly associated with this outcome. However, in the multivariable analysis, only formal employment remained independently associated with virological suppression. Thus, trans women with a job other than sex work were approximately 8 times more likely to be virologically suppressed at 12 months of their HIV diagnosis. Importantly, and although the numbers are small, this association remained even when we adjusted for current ART use. Altogether, these findings suggest that unemployed trans women or those engaged in sex work may have other competing interests such as housing, food sources, or even their personal safety that could make staying on ART a low priority even within Argentina's universal healthcare system that guarantees free HIV care, including ART, to all HIV-positive individuals living in our country. Finally, in an explorative sub-analysis, we sought to estimate the impact of the new Argentinian legislation on engagement in HIV care among our trans women population. To meet this secondary aim, what we did was to compare rates of engagement in HIV care before and after the Buenos Aires city policy was implemented in the year 2007, which are represented in this figure by the green and purple bars respectively. As you can see, although no statistically significant difference were found in any of the steps of the cascade, there seems to be a trend towards higher rates of undetectable viral load in the later period. And maybe this lack of statistical significance difference is due to lack of enough power due to our small sample size. Our study has several limitations that include, first, its retrospective nature. Second, that we only focus on trans women enrolled in one HIV public clinic in the city of Buenos Aires, and therefore our findings might not be generalizable to the whole HIV-positive trans women population in our country. And third, that given the small sample size, we had limited statistical power to perform the different analyses, and therefore the results presented here should be interpreted with caution. In conclusion, our preliminary findings suggest that despite significant efforts to address social and legal barriers to increase access to care, rates of engagement across the HIV continuum of care among our trans women population remain low. The high proportion of substance use, sex work, and unemployment observed within our population suggests that factors operating in the broader risk environment of transgender women might be shaping their HIV outcomes. Therefore, novel and culturally appropriate interventions tailored for HIV-infected trans women are urgently needed to improve both their clinical outcomes and to also reduce the secondary risk of HIV transmission. In response to this, and recognizing the unique characteristics of these populations, since August last year in our hospital, we have assembled a multidisciplinary team with the aim of providing comprehensive health services adapted to trans women's needs with the ultimate goal of increasing their access to and retention in care. Finally, I would like to thank both my colleagues at the Infectious Diseases Division at Hospital Fernández and Fundación Westfield. Thank you very much.
We have time for a number of questions. Could I ask, is sex work legal in your jurisdiction, and what impact do you think that policing and so on has on your engagement and provision of service?
Yes, in Argentina, sex work is legal, but even though it's legal, there is a lot of interaction of police with sex workers, not only with trans sex workers, but also with female sex workers, which usually arrest them just to arrest them just because they are maybe holding condoms, even if it is legal sex work. And in fact, we have a paper in review right now, in which we have found that those transgender women, not only sex workers, but who report having more experiences with police interactions, report to avoid healthcare more often than those who doesn't. So maybe there is something to consider when we talk about engagement, not only in HIV care, but also in other healthcare.
Your finding of employment being associated with better outcomes in the Cascades, very interesting. And you alluded tantalizingly to new interventions. Are you thinking of looking at either the use of peer health navigators or conditional cash transfer as interventions to improve outcomes in the Cascade?
Well, that could be something to consider. Also, as I have mentioned in my presentation, in 2012, the gender identity law was enacted. And we hope that that when trans women are able to acquire a new ID that is congruent with their gender identity, they will be available to access to more job opportunities and also to housing assistance and other welfare that may also increase their access to healthcare. Also, another thing that we think that could help to enhance their engagement in care is the integration of transition medical care into HIV care. Trans women highly prioritize the hormone treatment or other surgery, so that could be something to consider.
Great. Well, thank you very much.